Good morning, everyone. This is Carrie Beck, and welcome everyone to our webinar this morning. We have a very exciting speaker this morning, Dr. James Wilson from the Nevada Medical Intelligence Center. Presentation is officially titled Using Community Antibiograms and Data to Drive Antibiotic Stewardship, and it's all about antimicrobial resistance intelligence. Again, my name is Carrie Beck. I'm a project manager with HealthInsight, and I am the task lead for this project with HealthInsight, looking at or focusing on antibiotic stewardship programs in the outpatient setting. So first of all, I want to let everyone know that this event is being recorded, and the recording will be available following this presentation in about a week or so, and we will email that out, a link to that recording out to everyone. The slides will not be available, but the recording will. Also want to call your attention to the chat function. I'm sure all of you are familiar with this function. Feel free to chat in your questions during the presentation if they come to your mind, and we won't stop and answer them during the presentation, but we will make sure to go back to them when we have a Q&A session at the end of the presentation. So chat them now or chat them later, hoping for a lively Q&A session. So next, I just want to give some brief information about the organization that I work for, HealthInsight. HealthInsight is known as a Quality Innovation Network, Quality Improvement Organization, or uses the acronym QIN, QIO. Some of you may be familiar with that term. One of our funding sources for HealthInsight is through CMS for quality improvement projects for Medicare. And one of the tasks that we are funded for, as I mentioned, is for development and maintenance of antibiotic stewardship programs in the outpatient setting. So this project is really exciting. We have many other Medicare projects, but that is the one we are focused on today. HealthInsight works with stakeholders to provide quality improvement education and technical assistance, data-driven quality initiatives to improve patient safety, reduce harm, and improve health and healthcare. We do leading edge research and several other services. So that's just a bit about HealthInsight. I am now going to turn it over to one of my colleagues who is the Nevada State Lead for the Outpatient Stewardship Task, Vicki Kohler. And Vicki, I'll turn it over to you now to introduce our speaker today.
Thank you, Carrie. Good morning, everyone. I'd like to introduce to you today Dr. James Wilson, who was kind enough to do this presentation. I think he's got some great information and insight to offer us on antimicrobial stewardship, antibiograms, and his ARIS detection system, forecasting system. Dr. Wilson's the director of the Medical Intelligence Center at the University of Nevada, Reno. He is a board-certified practicing pediatrician who specializes in operational medical intelligence with a focus on the anticipation, detection, and warning of infectious disease crises. He was the first operations chief of the Department of Homeland Security's National Biosurveillance Integration Center. He led the private intelligence teams that provided warning of the 2009 H1N1 influenza pandemic, discovery of the United Nations as the source of the 2010 cholera disaster in Haiti, and several investigations in alleged and confirmed biological weapons deployments. Dr. Wilson's a strong advocate for effective and accountable global health security intelligence and the need for credible, balanced threat assessments. He is currently, and most excitingly, working with Harvard to develop a book discussing health security intelligence. So with that, I'm going to pass off to Dr. Wilson now to go ahead and begin our great presentation today.
Okay, can everybody hear me okay? Okay, everybody's muted, I guess. Okay, so we'll assume we're good. So this is a system that we're going to show you today that is really designed to capture a specific aspect of antimicrobial stewardship activities. So just so that I'm telling you guys where I'm at with stewardship, this is the definition that I'm referring to when I say antimicrobial stewardship, and it comes from 2007. And really what we're looking at is to improve how we use antimicrobial medications, right? Because we are noticing that there's increasing drug resistance amongst a lot of different microbes. The focus for us, though, is bacteria. So we certainly could focus on a conversation around viruses like Tamiflu and influenza. We could talk about resistance in fungal, amongst fungal species, but that's not the purpose of our initial effort because it relates to targeting, really. We're focused on bacterial disease, which is really responsible for a significant cost in healthcare if you look at all possible applications of antibacterial agents. So when I say the term antibiotic during this presentation, what I'm referring to are drugs that are used to treat bacterial infections. Now, I'm going to use Northern Nevada as an example, and this was kind of the approximate threat assessment that we did a couple of years ago. We were looking at urinary tract infections. Urinary tract infections are responsible, or suspected urinary tract infections, I should say, are responsible for an awful lot of antibiotic prescribing and a lot of antibiotic overuse, particularly asymptomatic bacteria. UTIs represent about 8% of all hospital admissions, up to 1/3 of ICU admissions by our estimates here for our community. E. coli is the dominant pathogen. So E. coli, just to keep this in perspective here, this is the #1 bacteria that's isolated out of clinical laboratories in medicine, right? So this is a bacteria that lives in our gut. It helps us digest food, and it's a very important pathogen for our patients. Now, typically we see this be an issue, of course, in the very young and the very old of our patients, but it's a good proxy marker for community-level drug resistance. Multi-drug resistance is associated with a 3-time mortality rate in the ICU setting. Just to kind of keep that in perspective, just keep that in the back of your mind because I'm going to show you evidence of where we stand with E. coli in terms of resistance. Cipro is the #1 drug prescribed in Nevada for urinary tract infections. Now, Cipro is actually not recommended by the Infectious Disease Society of America for frontline treatment of uncomplicated UTIs. But nevertheless, it is used like candy. It's just handed out all over the place. And we have a horrible problem with drug resistance now as a result. E. coli became resistant to Cipro in 2005, unnoticed in our state. We're estimating about $312 million in healthcare expenses in Washoe County and Carson Valley just for urosepsis annually. And those figures are derived from looking at ICU admissions. We do have a very high percentage of our population who are older adults and very sick patients here as a result. We have a bad problem with Clostridium difficile. So we look at C. diff as an important endpoint marker for lack of stewardship. So if your C. diff is out of control in your community, that's a community marker for lack of antimicrobial stewardship. Here in Washoe County, it's a major problem. We actually do seasonal forecasting for C. diff, and we do see seasonal peaking of C. diff that's probably related to overprescribing, seasonal surges and overprescribing of antibiotics. So what did we do about this? So this is an elephant, right? And you have to, if you want to eat an elephant, you got to do it one bite at a time. So what we decided to do was to build a system that's available online that is capable of ingesting antibiogram data. And what an antibiogram is, and I'll show you an example of this in a second here, is a facility report that kind of takes a very high level picture view. It's a population level view for that facility of what level of susceptibility you're dealing with your bacteria. Are your bacteria all 100% susceptible, or are they somehow falling short of that nice green target, right? And I'll give you an example of this in a second, and I'll explain it in more detail. But the idea here is that we wanted people to be able to have a place to manage their antibiogram data and then be able to consider that data across multiple healthcare facilities, care dispositions, and age groups. And then with Arjun Srinivasan's kind assistance, we over at CDC, we implemented some automated assessments based on proposed international standards for describing multi-drug, extremely drug, and pan-drug resistant status, and implemented those inside the system. So when you upload your antibiograms, the system will automatically retain that data, analyze the data, and then start giving you preliminary indicators of where you are with your different bacterial populations. Are you MDR, XDR, PDR, and are those patterns going to hold for the next 5 years, kind of thing. Now, resistance pattern forecast, quote unquote, and I know that word can be tricky for some folks. If I use that word in front of an epidemiologist, they have a seizure. They like to use the word prediction. So if you find that word forecast makes you twitch, just replace it with the word prediction, right? And what we're trying to do here is show people the trends of the data. Where have you been, and where are you going to go if nothing changes, if you don't do anything about this problem, right? So it's a fairly simplistic thing. But what we're trying to do is to goose people into a proactive management posture as opposed to reacting to data that was collected over the course of a year and presented as a product that is for the here and now. But oftentimes what people do is they're just looking at last year's antibiogram, and that doesn't really give you a lot of insight into how fast are your susceptibilities degrading by care disposition and age group. What we have found over the last 2.5 years of doing this work is that pharmacists are really the key. They are the ones, and this is in contrast to infectious disease physicians. There are a couple out there that really are on top of data analysis, but when we present antibiogram data to people in a healthcare facility, it's the pharmacist that understands that data and understands most importantly, what to do with that data. And so I have a very strong bias to working with pharmacists and to recruit them as beta testers on this system. So and we'll get through this. We're gonna walk you through some screenshots of the system, explain what it's doing. But the idea here again is that the pharmacist would be able to manage all this data online and be able to release cuts of that data to the frontline healthcare providers that we're trying to influence. So to summarize, this whole system is looking at the specific area of stewardship that is focused on appropriate empiric prescribing behavior. Okay, so we know that a significant portion of antibiotic prescribing is unnecessary, right? That's not necessarily the piece that we're tackling right now. What we're tackling is if you do have to prescribe an antibiotic for a given disease, for a given patient, in a given care setting, that prescribing process is appropriate and informed by the so-called intelligence, right, which is the drug resistance data. Okay, so that's a very specific part of stewardship, not all of stewardship. Okay, so here's the opening screenshot is a lot of busyness, right? But this is an example of an actual data upload inside the ERIS system. And for each one of these lines here is an antibiogram, and I'll show you what that looks like in a second. The antibiograms are tagged out when you upload them into the system. So you have to tell the computer, hey, this data came from blood samples, right? Or urine samples, for instance. This data came from an intensive care unit, because a lot of times these facility antibiograms are broken down by care dispositions. If you have a really strong pharmacy team, they'll actually do these antibiograms down to the intensive care unit. They'll do it to the emergency department level, the inpatient general ward, or the outpatient urgent care setting. And if they do that, then that gives you rich information. And it's really important to do that if you can do it, because you will notice differences in drug resistance patterns between these different care dispositions. On the right there, you'll see that there are age groups. We also tag this data based on your patient population. So if you upload an antibiogram, the system asks you questions. Hey, does your facility mainly deal with adults, or is it kind of a wide open community facility where you can see babies, you can see children, you can see adults, and all age groups basically, right? And so if you think about it, you're looking at basically 3 different age group categories, right? Babies, children, adults. And you're talking about multiple care dispositions. So we also have LTACs and SNFs represented in here as well. Now here's an example of an antibiogram. On the left there is a column that describes the bacterial species, right? So methicillin sensitive staph, or MRSA, or strep pneumoniae, or enterococcus. And these different bacteria are tested. What happens in the lab is they grow them up in culture, and they test their growth against different antibiotics, okay? And the number of isolates there is important. You need to have isolated at least 30 per data sample, and usually the antibiogram is created once a year. So over the course of a year, you want to have at least 30 samples to have a statistically significant sample size. So this is per the recommendation from CLSI. And for what the system does is typically this data just looks like a static Excel spreadsheet, without any color on it, right? And so what the system does is some simple things. The threshold is 85%. We want these bacteria to be susceptible to the above drugs that are listed across the top of the chart there. We want them to be susceptible to the level of 85% or above at the population level, right? So anything that's green basically tells you that for that bacteria and that drug, it's okay to consider using that particular drug. All right, so that's a very simplistic explanation. Anything that's grayed out, you can see that some of the cells in there are kind of whited out. That's giving you a warning that you're not achieving statistical sample size. So if you use that data, just be careful, because your sample size is very thin. Yellow is kind of an intermediate level, and then red, is a warning. Red says, okay, you probably shouldn't be using that drug for that bacteria. Now the challenge here is if you talk to your frontline healthcare providers, whether they're a nurse practitioner or a PA or a family practitioner, a physician, is people, I don't really care who you are, you kind of have to sit back and think a minute, okay, if we're talking about Klebsiella, then what diseases is that associated with, right? If you're talking about Enterococcus, what patient population diseases are we talking about? And so I used to run around and show people this data, and I used to show them, the trend lines and everything. And what I found is that the physicians just didn't understand what they were seeing, and they had a hard time putting it in context. So we had to take the system a couple extra steps forward to try to help connect those dots for them to make it easier to use. So the next slide here, and we'll come back to that in a second. The next slide here is the automated facility assessment. And so what you're seeing here on the right-hand side is, if you go from left to right, we're looking at an adult population in this example. This is real-world data, by the way, from our state. The adult population, the care disposition at the top there is outpatient, for example. And we're assessing E. coli, staph, Pseudomonas, right, in the E. coli setting. Now, E. coli, the system is assessing it to be MDR status, multi-drug resistant status. Yeah, it's been MDR for 10 years now, and the projection for the next 5 years is it will remain MDR status. Pseudomonas, MDR status, no big surprise there. We all know that Pseudomonas is very difficult to treat. Staphylococcus, interestingly enough, based on the outpatient isolates from this particular facility, did not show a very high MRSA presence, okay, and so that's why it was listed in green. Now, other facilities, that is not the case. Now, in the if you drop down to the emergency department setting, just skip over urgent care, look at emergency department, you'll see Acinetobacter will show up in there. Now, Acinetobacter is a little bit tricky. This is the bacteria that's typically associated with ventilated patients, especially in the LTAC setting, and it says PDR there. Now, technically speaking, we can't really assess pan-resistant status except at CDC, right, where they have specialized testing for all known antibiotics, right? But from a practical community perspective, we have access to the antibiotics we have access to at the local setting. And so what the system is saying is basically, look, you tested Acinetobacter against XYZ antibiotics, and not a single one of them was found to be, susceptible. We did not meet that 85% threshold, right? If you scroll down further, you'll see that our Pseudomonas in the intensive care unit, for instance, and inpatient settings is XDR status and is projected to remain at XDR, so that's extremely drug resistant. So really this gives you a very, very high level indication of where your population is. Now keep in mind, it's kind of like a radar system that gives you a tip, right? It's giving you an indication. It's not a confirmation. Confirmation would be you have a patient who is in the intensive care unit, you draw their blood, you send it down the lab, and the lab comes back with a patient level report that says, hey, what's growing out of this patient's blood is XDR whatever, right? And so there's a difference between the population view that's offered through the antibiogram and then the patient level view. So we always kind of want to keep that in mind, is that this is a system that's looking at this from a very high level. Here's a zoom in. Now in this slide, I'm showing you the difference between adult and children. On the children's side of things, it doesn't look quite as bleak, right? And so you don't see as much red in here. And so so what we've noticed in our trends is that when you're dealing with pediatrics, we're not seeing as ugly looking a resistance pattern as we see in the adult population. Now, in the adult population, that's covering a wide swath of ages, right? It's from 18 all the way up to 90 years old. And we know that the elderly patients and the LTAC patients, of course, can influence these numbers. So you got to keep in mind what's in this data. The next slide, this is an example of a given antibiotic. In this case, it's Cipro. And from the left to the right there, the left upper hand box there that's in red, that's Acinetobacter. So basically, everything we have tested over the years, we've tested Acinetobacter against Cipro, and basically it just doesn't even show up on the graph because it just simply isn't susceptible. Then we have Cipro and E. coli, and for this particular cut of the data for this care disposition, this age group, we have signs of hope. We may see a return of susceptibility of Cipro someday, but we're still well below the 85% threshold. Enterobacter is the next one, Enterococcus, and then it's broken down by Enterococcus faecalis, Klebsiella oxytosa, Klebsiella pneumonia down at the bottom left, MRSA, MSSA, Proteus, Pseudomonas. So the point here is that as soon as you upload your antibiogram in the system, within, I mean, I'm not kidding, it's almost instantaneous. You click the next button and you can see your profiles, right? The next slide this is the view of E. coli. Okay, so now here is an example of some challenges with E. coli. On the upper left hand there in green, this is amikacin. So we're looking pretty good over the years for amikacin. Augmentin, not so much. We've had some challenges with Augmentin. We used to be close to 100%, and for some of the facilities, some of the care physicians, they were able to hold out. But generally speaking, it's off the table for us. AMP, of course, off the table. As Trionam, we've seen some variants there where it's threatening to, in some facilities, it's not a good drug to choose. In other facilities, it is, and so on. For the third generation cephalosporins, we're looking at about 15 years left before we cross the 85th percentile overall across all care dispositions. So that's a concern for us, right? And so really what we're trying to do is get our hands around the data, try to understand, what the data has its warts, it has its problems. We all know this. The antibiograms are not perfect. We do know that they're not standardized at different, some labs are using FDA cutoffs, others are using CLSI cutoffs. And really what we're looking at here is an attempt to get our hands around the data, as messy as it is, to inform our clinical decisions. So what do you do with all that data? That's a lot of data, right? And if you think about it, that's a lot of data across a lot of different care dispositions, facilities, age groups, right? How do you get your hands around this? Well, the system has an ability to connect that data to what we call the empiric prescriber guidance. And this is an example of the interface here where pharmacist goes in and he selects what disease he's going to draft an empiric prescriber guidance for, and then selects the age group, the care disposition, and the bacteria of concern based on their knowledge for that care disposition. The system can help you analyze which bacteria, the most common bacteria by care disposition, by the way, you know, in case you may not know that. So in this case, this pharmacist was concerned about drafting guides for adults seen in the emergency department where his primary concern was E. coli. And so what he's basing his guidance on is the 5-year so-called forecast, which is nothing more than a linear regression trend line carried out 5 steps in the future at this point. We are augmenting this with other prediction packages. But the point here is what we're trying to do is get people to think ahead. You know, just the way things are done right now is they will use a static antibiogram based on last year's data, okay? So it's potentially year-old data that they're trying to look at. For some of these bacteria drug combinations, we have some fast-moving bacteria that are gaining resistance very quickly. And what we don't want is people, you know, kind of running these drugs right into the red before they realize what's going on. And so this is the purpose of a 5-year prediction is to remind them to think ahead, you know, that we want to preserve, you know, really good access to these antibiotics and use them appropriately. So in the box there to the left of the antibiotics in the green there, the pharmacist would select that, and then a prescribing draft window would open up, and then they would actually input the dosing levels and all the notes associated with that guidance. And so the next slide here is the clinician query. In the clinician query, this is the side that the clinician sees, and they can access this by their cell phone. And what they do is they go up there and they do a drop-down menu for the facility. And then they do the disease system and type, the care disposition, the clinical severity, and the age group. And again, if you think about this, this is where we have you know, lots of challenges trying to coordinate all this data, is you really are looking at different empiric prescribing guidances depending on how that patient, you know, where that patient is, who they are, how severe their disease is, et cetera. Okay, so it turns into a fairly large database. So here's an example of a prescriber guidance that was drafted based on the intelligence, is that the pharmacists are actually able to deploy this very quickly to their providers. Now, obviously, the first time that a pharmacist does this process is a little painful because they have to enter everything in, you know, that first time. But when you come back and update it over the years, you only have to update a few of these and really only every now and then, depending on what your drug resistance profiles look like. So it's a lot of upfront work, but once you get it done, you know, you have this rich database that is easily accessible by mobile phone. So sort of to wrap up where we're at with this, this system was used to create the first community-level outpatient and LTAC SNF empiric prescriber guidances in our state's history. Those were recently deployed through our accrediting agencies, so the Board of Medicine and Board of Pharmacy. And that kind of sent a notice out to all of our healthcare providers that, hey guys, you know, you're not going to be allowed to really prescribe anything that you want anymore. You know, we need to look at our data. This is coming from the Board of Medicine, so this has some degree of gravitas to it that you need to start, you know, adhering to these recommended guidances, right? So it's a warning. It's not anything that we can hold their feet to fire yet. We don't have regulations that, or any kind of process that can ensure compliance, and I'm sure there'll be a lot of Q&A about that aspect of this. And I do have some guidance from Joint Commission I can share with everybody if they're interested. But the point here is that we're beginning to socialize people to the problem, right? And we're being very data-driven in that process. So next steps. We are right in the midst of beta testing. So the system right now sits on an academic cloud server with, you know, and is written in academic code. And as many of you have guessed, this is a fairly technical system. So it's not a warm and fuzzy interface like a Google interface. And so someday we would like to see it get to that point. So it's a lot more user-friendly. But we do have multiple IDSA members engaged in beta testing across 20 states and 4 countries. The expansion of the system will eventually include other aspects of stewardship, like the days of treatment analysis, financials, and there are other products on the market that deal with those aspects of stewardship too. But the most important thing that we've noticed in engaging in the platform, honestly, is the networking among peers. And so when we engaged IDSA members, we gave them the intelligence outputs and then asked them to form groups by specialty. So for example, when we drafted the LTAC SNF and empiric prescriber guidance, what we did is we grabbed infectious disease physicians and infectious disease pharmacists who identified themselves as primarily working in the LTAC SNF setting, and pulled them into a group, had them review the intelligence, and then help us craft empiric prescriber guidances, right? So it became a very specialized activity. And the issue that we're trying to address there is many of our facilities do not have a pharmacist on staff, or they have a consultant pharmacist, and they don't have the in-house expertise. And so what we're doing is we're leveraging the power of crowdsourcing, honestly, amongst peers, subject matter experts, right, to come together and help us look at the data, at least at the empiric prescribing level, as a starting point. And what we noticed is that when these peers got together, they themselves had to have a little bit of a debate and a conversation around the guidances. And so what we're looking at here is the beginning of a social network to support antimicrobial stewardship, where the experts really do need to help each other. And what's interesting is they're not used to working with each other on these issues on a daily basis. So Bob in Montana comparing data with Joe in South Dakota, hey, are you seeing this resistance pattern? This is what I'm seeing. This is the prescriber guidance that I've drafted against this. What do you think? This kind of discussion to me is really where the real firepower is going to be with all of this. So I'm going to close with my contact information here. We are looking for beta testers, and we would absolutely be thrilled to include you all in that process so that you all can have a chance to come in, kick the tires, and give us some feedback on how we can design this thing even better and more user-friendly and to answer the need. And so with that, I'll go ahead and close out and I guess open it to Ms. Beck for Q&A.
Okay. Thank you, Dr. Wilson. That was very interesting, and we appreciate all of that really in-depth information. There are some questions coming in, which we do have time for, so if you don't mind, I'm gonna go to those questions. Let's see, Q&A, here we go. So we have two questions from Terry in New Mexico, Dr. Wilson. She's asking, how can I learn if and who in New Mexico is creating these, referring to the antibiograms, I assume, and then how are these antibiograms being used in primary care settings?
Okay, that's a great question. So in our state, what we decided to do is primary care is like herding cats, right? There's a million different primary care groups. And so what we decided to do is we went to Quest Labs, which was the primary commercial vendor for laboratory diagnostics in the outpatient setting in our state. And they had enough data to give us a credible sample size for the outpatient population. And they gave us antibiograms. When they gave us antibiograms, we asked for 10 years of antibiogram data, which they gave us. And then we were able to upload those into the system. And literally within seconds, we were able to see what our trends look like, and then where are we going with these empiric prescribing guidances. And then we assembled the team of people to put together the prescriber guidances. And then we deployed those specifically through the Board of Medicine for our state, because if I sent it out from my personal email here at the university, even though I'm a pediatrician, people would probably blow me off, right? It's a different story if it shows up in the Board of Medicine monthly newsletter, different story if it shows up coming from the Board of Pharmacy, right? So you have to think about how you're going to distribute the prescriber guidances. But who produces it for your state? when it comes to primary care, the first question to ask is, who is the primary commercial vendor for laboratory diagnostics for your state? And if it's LabCorp, then you go to LabCorp. If it's Quest, you go to Quest. Now, I will tell you that we have noticed that LabCorp is not quite as up to speed on the ability to give antibiograms based on their data as Quest is. Quest is a little more advanced. So if you have Quest in your state, you're well prepared. Okay. Now for some primary care settings, it's owned by a healthcare center, a hospital, right? And if that's the case, then you go to the head pharmacist for that hospital or the head of the laboratory. So it's one or the other. The clinical microbiology group will oftentimes be the publisher of antibiograms for a facility and its subordinate care dispositions, or it's the lead for pharmacy. I hope that answers your question.
Thank you, Dr. Wilson. We have another question from Pat Preston, and Pat is from the Center for Geriatric Infection Control. And Pat asks, are you accessing data from large local or regional private labs to which many nursing homes send their clinical specimens?
Yes.
If those labs generate an antibiogram, can a distant rural nursing home effectively implement the data for their ASP?
That's a great question, and the short answer is yes. And for the LTAC SNF setting, we did break it down for example, for our LTAC SNFs, we carved out northern and southern Nevada and separated them. But we had, we definitely have this concern, and I share the concern of, how appropriate is it to look at regional antibiograms? The ideal here, honestly, is if you have a sample size for each of these bacteria antibiotic pairs of at least 30 for a year's collection. If you have enough statistical sample size, then you want to go as local as you can, as the data allows, right? Is kind of the guidance that we were given and that we've been following. Now, in our state, we have huge, we have areas that are separated by hundreds of miles, right? And so Vegas is very different than Northern Nevada, for instance. And they're a very quickly growing metropolitan area, in fact, one of the top 5 rapidly growing metropolitan areas in the United States. And what that means is, the implication is that their drug resistance patterns are going to look worse than up here, which is more sparsely populated, right? So we have to be careful about that and mindful about, okay, what's your patient catchment area? What's the population you're serving? Are they relatively isolated, or are they heavily networked, right? So the way we would do this in San Francisco would be a little bit different than the way we do it in Northern Nevada. And what we're trying to do is defer to the expertise on the ground who really understand their own population the best. We're trying to provide them with this tool to help them analyze their own data, but they need to kind of choose how, what data source they're using and how appropriate it is to mix, data from different facilities, et cetera. Oh, and there's
our next question. Oh, go ahead.
There's a question on the chat line about TED Talks. I did give a TEDx talk on this, and it was, it came from the perspective of infectious disease forecasting, and I was really more focused on anticipation of infectious disease crises, and I did have a couple slides on antimicrobial stewardship in that presentation, and I'll try to remember to send the link to Vicky Kolar. But yeah, it was a rousing talk. If you're interested in beta testing, my email address is right there on the screen, and as well as my phone number. So please feel free to reach out to me or reach out to HealthInsight. We'd be delighted to include you as a beta tester.
Yes, and I encourage everyone to please reach out to us, or as Dr. Wilson said to him, and encourage you all to get involved. Dr. Wilson, we have a couple more questions. Is that okay?
Oh, sure.
Okay, we have a question from Robert, who says, to kick the tires, is it necessary to send you our facility data to upload into this database?
No. We started out with that because we were naive about how difficult it is to get corporate to sign off on this stuff. So no, I've already walked through that parking lot of broken glass and bare feet. So I'm gonna, here's the way we're doing it right now is we uploaded real world anonymized antibiogram data from some of our facilities here in Nevada into a demo account. And what happens is the beta testers simply use the demo data. So we don't have to sign data sharing agreements or confidentiality or anything like that. That we let you basically look at the demo account with the demo data, but know that it's real world data.
Thank you. Our next question is from Samantha, and she asked, you discussed empiric treatment. Do you recommend follow-up cultures? I see lots of antibiotics for UTIs and sniffs without UA, CNS. I don't know what UA and CNS means, but I hope you do, Dr. Wilson.
Oh, I do. So UA stands for urinalysis, and CNS, okay. CNS is where the rubber meets the road. That's where they have actually cultured the urine, grew out the bacteria, and tested it against a panel of antibiotics to see what that patient's bacterial resistance profile looks like, right? In the LTAC sniff setting, I think that's critically important to do that. I mean, I don't know why people don't do that, but that's my personal opinion. I know that some physicians feel like they can just wing it without a CNS. I'm not sure that that's, in today's world, the level of crisis that we're dealing with, I'm not sure if that's appropriate. You know, I think that at this point, especially in the LTAC sniff setting, you want to get those cultures and sensitivities so that you understand what's going on, because even at the patient level, you will see patients develop multi-drug resistant bacteria over time if they're frequent flyers in those care settings and are given, you know, multiple rounds of antibiotics. So you really need to kind of be on top of that and know what's going on in your facility. The only way you're going to know what's going on in your facility is if people are doing cultures and sensitivities. So knowing that, right, realize that in the outpatient setting, primary care setting, we don't do a whole lot of cultures, right? So I'll give you an example. As a pediatrician, what do I give antibiotics for? Well, I give them for strep throat mainly and for ear infections, okay? And actually rarely for ear infections, thanks to the Prevnar vaccine. And so in the old days, doctors, these crazy old doctors, used to put needles in kids' eardrums. I'm not making this up. And they would suck pus out of the eustachian tube there and send them down to the lab and grow out the bacteria. Now, I don't know what mama in this world, in today's world, would allow me to go and stick a needle in her kid's eardrum and suck out the pus. So we don't really do that, right? So for some of these diseases, we are flying a little bit blind, and we're going to have to defer to CDC guidance on that, okay? And the and so we're looking at national level guidance on that, which is a little bit challenging because we do know there's variation in resistance depending on what locality you live in. So everyone's drug resistance weather, so to speak, is different, you know, especially the urban areas. You know, the more urbanized you are as a general rule, the more of a challenge you've got with drug resistance, you know. We have noticed, coming back to the prior question about CNS, whether or not people are doing cultures and sensitivities, we've noticed that people oftentimes are misled to think that they don't have a drug resistance problem. The reason why is because they're not collecting the data. If you don't collect the data, then you have no earthly idea what's going on in your facility, and you really don't know what's going to happen in the next 5 years. You may be, I'll give you some examples here in our state. We made some pretty ugly discoveries of just how bad drug resistance was in our state simply because we were analyzing the data. So this is a little bit of an adventure, right? Beware what you wish for. When you start looking at this data, you're going to start raising some eyebrows, no doubt. And you're going to say, holy cow, we really do have a problem. Now, I think this is super important to do this because what I have found talking to physicians and infection preventionists, et cetera, is that a lot of folks are referring to CDC reports, right? Which is a good thing to do, but it's one thing to get a report coming out of the so-called ivory tower in Atlanta. It's a whole nother deal if you're looking at your own data in your own facility and you realize how deep a doo-doo you're in your own facility, right? You've got to make the risk and the threat relevant, and you've got to make it locally relevant to you and your physicians. That would be my strongest recommendation.
Comment? Thank you, Dr. Wilson. We have a comment from Libby who says that yourself and HealthInsight Nevada graciously contributed articles to the Nevada State Board of Medical Examiners in their newsletter. And Libby is giving us the website and the newsletter number to access that one. And Katie has posted that in the chat if anyone is interested in reviewing that article.
Yeah, major shout out to Libby. That she's, I mean, honestly, I've never worked with a state medical board as proactive and as advanced as ours. I mean, in terms of just saying, hey, we're gonna grab this bull by the horns and go ahead and put this out there. I mean, our board is awesome. I mean, so yeah, Libby, I didn't realize you were on the line. So kudos.
That's great. We also have a question from Bassam, and Bassam is sorry if it was missed, but is there any place for community pharmacists to participate in this program?
Absolutely. In fact, they're where the rubber meets the road. So one of the interesting and compelling things that our Board of Pharmacy suggested is they have collaborative practice agreements in our state now. And this is all new to me, like as of just a couple weeks ago. It kind of blew my mind as a pediatrician, where now there are some practices where the physician says, okay, ma'am, you've got strep throat. Go to this pharmacy and they'll treat it. And they don't write a prescription. They go down to the pharmacy and the pharmacist writes the prescription. Now, that's pretty cutting edge, right? And that's a real mold breaking process right there. You're going to have some physicians that are going to completely rebel against that concept. But to me, that puts the community pharmacist right there in the driver's seat as their community data analyst, right? And so to me, community pharmacists are a critical part of this because they do participate in patient education. So one of the aspect of all of this that we really haven't talked about today is the number one driver of all this garbage that we're seeing here of overprescribing is patient demand, right? And so one of the things that I've taken to heart here is the notion that anyone we can get our hands on out in the community, we want them a part of this so that they can show the people they're talking to the outputs, show them the graphs, show them everything in red, show them that we're multi-drug resistant E. coli, for heaven's sake, you know, that we can't keep driving our community down into oblivion here, because there's going to come a day when we don't have access to antibiotics, which is, I don't think people can really get their heads around what that really means and how bad of a situation that is. So, I mean, really a huge shout out to community pharmacists. They are the ones that can call the primary care physicians up and say, hey guy, do you really want to put, you know, Aunt Mary on Cipro, you know, for this asymptomatic bacteria? First of all, is it really appropriate to start antibiotics for asymptomatic bacteria, right? I mean, so to me, pharmacists are a major component to this.
Thank you, Dr. Wilson. I have a question. I'm wondering, in one of the reports that you showed, there was a column for cost, and I saw there were a couple numbers filled in that column, and I'm wondering, was that actually referring to the cost of the antibiotic? And if so, is that being looked at?
I'm glad you asked that because I forgot to cover that.
Get out.
Yeah, we threw some dummy numbers in there because we know that each healthcare system negotiates the cost, you know, their wholesale costs of antibiotics with the vendors. And so that's really an open column for pharmacists to put those numbers in for themselves, for their data, because we know everyone, I mean, those numbers are all over the place, right? And so we do know, though, that it figures into the calculus for empiric prescribing, especially in the outpatient setting. If you have somebody go out the door on fosfomycin, for instance, which is a very expensive antibiotic, then, you know, that's not going to work for many of our patients who are on Medicaid, right? That's a very expensive antibiotic, very difficult to get. Only a couple pharmacies in town have it. So that would be an example where you have to look at the drug resistance, but you also have to look at the, you know, whether or not your patient's going to be compliant. They're going to be able to actually go and get that drug, right? So there are other factors that feed into a pharmacist's decision to put this or that drug as a first line recommendation.
Great, thank you. I know in Oregon, there's been a real focus on the total cost of care, and so that's really helpful to have that information.
Now, so there's no database, by the way, Carrie, for that. So, so we tried to find a standard database for that. And if you look around for it, it's really hard to find, especially if you're looking at the difference between IM, PO, and IV formulation. So we just left that in the hands of the pharmacists who are using the system. By the way, I forgot to mention something. We have a huge black market here in Nevada for antibiotics, and this is mainly, these are imports from Latin America. And so when you go into some of the local grocery stores here, particularly in our Latino community, these mamas can go in there and they can buy over-the-counter cephalosporins without a prescription. And so it's one of many problems we deal with. You know, we have obviously an opiate addiction problem in our state as well, like many other states. So that, I mean, it's like one problem amongst a myriad of other issues that the Board of Pharmacy has to grapple with. But I wanted to say that because if you all are not aware of that, you need to be aware of that, that some folks, if they come to the clinic and you tell them, no, you don't need an antibiotic, they just go down the street, go to the grocery store, and they'll get what is supposedly a cephalosporin over the counter.
Wow, fascinating. There's one more question. Let's make this our last question so we close out on time. Dr. Wilson, Sherry has a question. It's how do you talk to families about using antibiotics in the absence of systems?
Well, you know, that's another great question. So Sherry, what I do is I actually open up the system and I show my parents the data. I show it to them. And you know what's amazing is people think that all this stuff is too technical for people to understand, but when I tell them that this is the most common bacteria that we deal with in medicine, being E. coli, and half of my screen is in red, right? They get it, they understand it. And they say, hey, I don't want a drug-resistant bacteria. I don't want to die of that. And so, you know, you have to be data-driven in your discussion. So I think what I found is that it has less impact if I try to verbalize it to them. It has greater impact if I can actually go right into my computer, which I already have in front of me anyway, because I'm documenting things in the EMR, and actually open up the system and show them this is our care setting, right? And I have yet to have a parent push me for access to antibiotics after getting that 5-minute talk. So, you know, it takes time, but it's worth doing it.
Thank you, Dr. Wilson. I am going to go to close out the presentation. I am going to switch to, and why isn't what I'm wanting coming up? Sorry. Oh, what I wanted went away. All right, there we go. Oh. Sorry, I'm having a technical difficulty right now. Not able to share my screen, Katie. All right, sorry about that. Am I unmuted, Katie? Yeah. Okay, great. Apologize for that. It never works when you need it to, right? I just want to close out by saying that We have a wealth of information and resources available from HealthInsight on establishing and maintaining an antibiotic stewardship program in your outpatient setting. And the website is on your screen, and there are some examples of the types of resources that we have. If you are interested in becoming more involved with HealthInsight on an antibiotic stewardship project, please feel free to contact us, or if you have any questions. And we do have this project in the 4 states that are part of HealthInsight, and I have the contacts listed on this page, including their email. So please reach out. And that is all for today. Thanks to Dr. Wilson for a really exciting webinar. I know there were several comments about how great the webinar was, and I second that, and we appreciate your time and expertise. Okay, we're signing off now. Thanks, everyone.